Thank you so much, Nojin. It's my privilege to be here representing with Nojin the WHF Federation, and it's a privilege and a personal pleasure to be here in China for my first time. So in the next 15 minutes, I will take this issue of the puzzle of heart failure with preserved ejection fraction. I have nothing to disclose, and I know you are very tired now, so I propose you only 5 questions. First, is dyspnea sufficient to diagnose heart failure with preserved ejection fraction? Is it frequent? Can we die of heart failure with preserved ejection fraction? Does heart failure with preserved ejection fraction have a single biopathology? And can we improve diagnosis, prognosis, and treatment of this entity? Just to address the first question about dyspnea. You know, one of the main problems with clinical trials in heart failure with preserved ejection fractions is to include patients just for having dyspnea and an ejection fraction, a normal ejection fraction. This is the problem with the one very important trial that is TopCat. I'm not going to address the many problems with this trial, but it was very surprising for us that aldosterone is not working in this situation. So here we have the patient with dyspnea, and you can see here that there are many reasons for a person to have dyspnea not having heart failure with preserved ejection fraction. So the main cause of dyspnea and is intolerance to exercise is the conditioning, and it's not similar, it's not equal of a heart failure with preserved ejection fraction. So it's important to go to the definition. This is the definition of the American College of American Heart Guideline, and for me this is a very short definition. It's just a patient with signs and symptoms of heart failure and with an ejection fraction, let's say, more than 50%. I do prefer the European Society of Cardiology guideline that introduce in the definition a patient with a normal ejection fraction, but with increase of BNP, and at least one additional criterion as relevant structural heart disease and diastolic dysfunction. I'm not going to speak about diastolic dysfunction, but you, as Dr. Sanderson said, diastolic dysfunction is an important concept and is very related with systolic function. So I do prefer this definition: a patient with symptoms and signs of heart failure, normal ejection fraction, but with BNP elevate, or at least one additional criterion, relevant structural heart disease or diastolic dysfunction. The second question is it frequent, this situation? Let's say that now it's more common heart failure with preserved ejection fraction than heart failure with reduced ejection fraction. So we can say that 50% of our patients with heart failure have normal ejection fraction and 50% have reduced ejection fraction. And can I die with this disease? Here you have 3 curves, one of the population, the other with patient with heart failure with reduced ejection fraction, and here you have in the middle the patient with heart failure with preserved ejection fraction. We can die. Probably we will die not for the heart failure, but due to comorbidities, as Dr. Nacarel said just a moment ago. This is, for me, the most important question. Is just one entity or a lot of entities? Because if you think about heart failure with reduced ejection fraction, the problem is in the heart. And there are two pathologies: coronary heart disease or cardiomyopathy. All is cardiomyopathy due to coronary heart disease or without coronary heart disease. This is the figure. But what's the case of heart failure with preserved ejection fraction? Here you have a lot of mechanisms that could be involved in a patient with dyspnea, with symptoms of heart failure, with elevated BNP, with some echo dysfunction. First, diminished diastolic reserve. As Dr. Sanderson said, there is a diastolic dysfunction, but most important is the less diastolic reserve, especially during exercise. These patients cannot adapt diastolic function to the exercise. There is also a diminishing of systolic reserve. There are problems with the heart rate, chronotropic incompetence during exercise. A very important part of the picture is the vascular dysfunction, the abnormal vasorelaxation, the endothelial dysfunction, and the increase of arterial stiffness. There is some problems in the coupling between the right ventricle, the pulmonary artery, and there is a relationship between heart failure with preserved ejection fraction and pulmonary hypertension. We can see autonomic dysfunction, problems with the AV different reserve, and a diminished cardiac output reserve. So, what's the message here? We have a clinical situation. This is a patient with heart failure or preserved ejection fraction, but a lot of mechanisms that could be the cause of the situation. Our last question: can we improve diagnosis, prognosis, or treatment? First, when I started in cardiology, let's say I'm an old man, so I'm a doctor for the last 40 years. Heart failure was with reduced ejection fraction. Then it appears something called diastolic heart failure. And now we call it heart failure with preserved ejection fraction. So what's the main tool for making diagnosis? Echocardiography. And now we have, this is the algorithm proposed to diagnose diastolic dysfunction. Diastolic dysfunction is a very, very difficult task. But we have three main criteria. First, left atrium volume. Second, EA relationship and EE prime relationship. With these three main tools, we can say this patient has a normal or abnormal diastolic function. So, if we think again about the different mechanisms we present, we can say that we have different phenotypes in heart failure with preserved ejection fraction. Let's say heart failure with reduced ejection fraction is a very homogeneous situation. This is a very heterogeneous situation. So we can have myocardial hypertrophy, interstitial fibrosis, myocardial inflammation and oxidative stress, and coronary heart disease. So the treatment has to be dependent of the mechanism. In the first case, we have the renin, aldosterone, angiotensin working. In the second, we have galectin, SST2. In the third, the activation of interleukins, CRP, TNF, increase of the matrix turnover, and biomarkers. And in the third, troponins. And the treatment couldn't be the same for all patients. In the first case, we have to act on renin, aldosterone, angiotensin axis. So ACE inhibitors, blockers, and ARNI. In the second case, I think that mineralocorticoid receptor antagonist is a very important tool, even after top cut. In the third case, weight loss could be metformin, AG-crosslink breakers, and statins. And in the third, ranolazine, ARNI, ibabradine, calcium antagonists, and beta blockers. So just to conclude in time, we have 5 questions. The first is dyspnea sufficient to diagnose heart failure with preserved ejection fraction? And our answer is no. We need some BNP or some echo evidence of diastolic dysfunction and structural disease. Is it a frequent entity? Yes, it is very, very frequent, and with age, diabetes and hypertension will be more frequent. Can we die of this entity? Yes, probably with heart failure with preserved ejection fraction, but probably due to comorbidities, especially renal failure, diabetes, etc. There is not a single biopathology for this entity. We have to think in each patient, which is the main mechanism playing the main role in this particular case. And we can improve diagnosis, prognosis, and treatment. So just to finish, I want to say, as Alvin Thompson said, the illiterates for this century will not be those who cannot read or write, but those who cannot learn, especially unlearn and relearn. So probably this conference will be very different in 5 years. Just to finish, I invite you, as Nushin said, to our Congress next year in December in the very nice city of Dubai. And thank you very much for your attention.